Hello, I'm Nizar Tanier. I'm a professor at MD Anderson Cancer Center in the Department of Genitourinary Medical Oncology. First, I would like to thank KCA and the organizing committee of this year's IKCS for the kind invitation to speak about nivolumab plus ipilimumab versus sunitinib for first-line treatment of advanced renal cell carcinoma in the CheckMate 214 study, with a focus on a 4-year follow-up and subgroup analysis of patients without nephrectomy. Here are my disclosures. The nivo plus ipi dual checkpoint inhibition regimen was approved for first-line treatment of intermediate and poor risk RCC based on superior OS and ORR over sunitinib in CheckMate 214 with a minimum follow-up of 17.5 months. Patients with advanced RCC who are ineligible for nephrectomy represent a population with high unmet medical need, and outcomes with immunotherapy in these patients are not well characterized. Here, in this presentation, we report an exploratory post-hoc analysis in a subgroup of patients without prior nephrectomy who had a primary target lesion intact, referred to in this presentation as patients with a primary kidney lesion. And we also will report the updated analyses from CheckMate 214 trial with extended minimum follow-up of 4 years, including survival, response outcomes by independent radiology review committee assessment, as well as safety. Patients who previously had untreated clear cell RCC, metastatic or advanced, were randomized 1-to-1 to receive nivo and ipi at the doses 3 milligram per kilo for nivo and 1 milligram per kilo for ipi every 3 weeks for a total of 4 doses, followed by maintenance nivolumab at 3 milligram per kilogram every 2 weeks, or sunitinib at the dose of 50 milligrams daily, 4 weeks on, 2 weeks off. Patients were stratified by region as well as by IMDC risk status. The efficacy endpoints for the trial included overall survival, objective response rate, and progression-free survival in intermediate and poor risk as the primary patient population, as well as intent to treat, which comprised all 1,096 patients randomized to the trial, as well as an exploratory group of patients who had favorable risk. Response outcomes were confirmed and reported, as I mentioned, by IRRC using RECIST version 1.1. This is also a non-pre-specified unplanned post-hoc exploratory efficacy analysis performed in a subgroup of CheckMate 214 patients with a primary kidney lesion in situ. The key baseline characteristics of the patient population with a primary kidney lesion, as well as side-by-side the intent to treat patient population, are shown here on the slide and are balanced between the two treatment arms. And as you can see, 53 patients had nivo-ipi and primary kidney lesion, and 55 patients had kidney primary lesion in situ and received sunitinib. This slide shows the waterfall plot showing maximum reduction from baseline in target kidney lesions as a percentage from baseline in all response evaluable patients, again with a primary kidney lesion. In green are patients who had a PR, in gray are patients who had stable disease, and in blue are patients who had progressive disease. In this subgroup analysis, patients who had nivolumab and ipilimumab, there were 49 evaluable for response, achieved a more than 30% or more of regression of their primary renal lesion in 35% of the patients versus 20% of patients treated with sunitinib who had more than 30% or more regression of their primary lesion. This slide shows the confirmed best overall response in patients with a primary kidney lesion, as well as the intent to treat, as well as intermediate risk, poor risk, and favorable risk populations, again with a minimum follow-up 4 years. As you can see here, patients who had primary kidney lesion in situ, The objective response rate was 34% in patients who were treated with nivo-ipi versus 14.5% in patients treated with sunitinib. As you can see, for the intent to treat, as well as intermediate and poor risk population, the nivo-ipi regimen produced a higher response rate than sunitinib. It is important to note that for the patients who had a primary kidney lesion in situ, there were no CRs. Now, this slide shows the confirmed duration of response in patients with a primary kidney lesion, as well as the ITT, intermediate risk, poor risk population, as well as favorable risk populations. As you can see, across those three subgroups, the patient with primary kidney lesion had a longer duration of response of 20.5 months median versus 14.1 months with sunitinib. As you can see, with a minimum follow-up of 4 years, for the intent to treat population, as well as the intermediate and poor risk populations, patients treated with nivolumab and ipilimumab had a longer duration of response compared to patients who were treated with sunitinib. The median duration of response for nivo-ipi treated patients with ITT in the ITT as well as intermediate risk poor risk was not reached. Now, for the favorable risk patient population, again, the median duration of response for nivo-ipi was not reached and was 33 months for patients treated with sunitinib. These are Kaplan-Meier curves plots for overall survival in patients with primary kidney lesion, as well as in patients with in the ITT patient population, in the intermediate risk or risk patient population, as well as the favorable risk population. As you can see here, for the three groups, the cohort of patients with primary kidney in situ, as well as the ITT population and the intermediate risk population, the overall survival was superior in patients treated with nivolumab ipilimumab. It was almost double the median for patients treated with nivo-ipi in that cohort of patients with primary in situ, 26 months versus 14 months with sunitinib. And as you can see here, in the ITT as well as in the intermediate risk to risk, the overall survival was superior with nivolumab and ipilimumab compared to sunitinib, and the median in the ITT population was not reached at 4 months, at 4 years minimum follow-up versus 38.4 months median with sunitinib. For the IP risk population, the median was 48.1 months with nivolumab ipilimumab versus 26.6 months with sunitinib. For the exploratory group of favorable risk, the median was not reached for both treatment arms, nivo-ipi as well as sunitinib. And as you can see here, the curves are intertwined, and the data as of 4 years minimum follow-up shows inconclusive evidence to support OS benefit or advantage for either treatment arm. Now, these are the Kaplan-Meier curves plots for progression-free survival in the cohort of patients with a primary kidney lesion, as well as in the ITT, intermediate poor risk, and favorable risk populations. Again, here the difference between the two treatment arms in the cohort with primary kidney lesion had a hazard ratio of 0.99, and in the patients with ITT, the PFS was, the hazard ratio was 0.89 in favor of nivo-ipi in the ITT patient population and 0.74 in the IP risk population. Whereas in patients with favorable risk, sunitinib treated patients had a superior PFS with a median of 28.9 months with sunitinib versus 12.4 months with nivo-ipi. This is a summary of the safety in patients treated with nivolumab plus ipilimumab versus sunitinib in the cohort of patients with primary kidney in situ, as well as in the ITT, in the IP, and the favorable risk populations with a minimum follow-up of 4 years. The treatment rates adverse events of any grade occurred in 96.2% versus 92.6%, with grade 3/4, 41.5% versus 59.3% in patients with a primary kidney lesion treated with nivo-ipi versus sunitinib, and 94% versus 97.4% with grade 3/4, 47.9% versus 64.1% of all patients. The incidence of treatment-related select adverse events, potentially immune-mediated across organ systems, skin, endocrine, GI, pulmonary, hepatic, and renal categories in patients with a primary renal lesion were comparable to or lower relative to the global study population. The overall safety outcomes in all treated patients was consistent with previous reports, and no additional treatment-related deaths were reported since the primary analysis. In conclusions, in this exploratory subgroup analysis of patients with a primary renal lesion, nivo-ipi offers a benefit in kidney tumor reduction, objective response rate, duration of response, as well as overall survival versus sunitinib. The overall survival benefit in this subgroup is consistent with that observed in the ITT as well as the intermediate and poor risk patient population. There were no complete responses observed in patients with primary renal lesion. In the overall study population with extended follow-up of 4 years, responses with nivo-ipi were deep and durable regardless of IMDC risk category. A complete response rate greater than 10% was observed consistently with nivo plus ipi, and most complete responses and partial responses with nivo-ipi were ongoing, around 65%. Median duration of response was longer with nivo-ipi versus sunitinib. Also, long-term OS benefits were maintained with nivo-ipi versus sunitinib in both the ITT as well as the intermediate poor risk patient population. OS results were not conclusive in patients with favorable risk. PFS was consistent with previous report, and curves continued to show a plateau above 30% with nivo-ipi in both the intent to treat as well as the intermediate risk poor risk populations. There were no new safety signals were identified with longer follow-up in all treated patients or in the subgroup with a primary kidney lesion. I'd like to acknowledge the patients and their caregivers who made the study possible. The study was supported by Bristol Myers Squibb, and would like to thank the teams that contributed to make this study available for you. Thank you for your attention.